So hi everybody, my name is Ki-Hung Lee. I'm a pediatric epileptologist. Basically I'm a neurologist with special training in treating epilepsy in children. Today I'm going to spend about an hour talking about very important points in diagnosing and managing epilepsy in children. So to start with, what are we talking about? Like any other disease, we need to really have a common definition among ourselves to communicate clearly. So when I talk about seizure, it means it's a sudden outward manifestation of excessive or abnormal electricity in the brain. And that could manifest as motor phenomenon, like jerking of arms and legs, or it could be change in their normal neurological functions, such as just lapsing into unresponsiveness or staring off, and so on. The seizures could be caused by many different diseases and different conditions, including epilepsy. So epilepsy is just one of the many different causes that could manifest as seizures. What is epilepsy? Epilepsy is the tendency toward recurrent seizures without very specific trigger. To make a diagnosis of epilepsy, you should have 2 documented seizures without any provocation. As I said previously, epilepsy could be caused by multiple causes. And just name a few: brain tumor, stroke, hemorrhage, and the brain malformation. Now, so why do we care? Because epilepsy is one of the most common neurological conditions in children. In the United States only, there's approximately 125,000 new epilepsy diagnoses. And when you look at 1,000 children, there is about 6 to 7 children affected by epilepsy. The epilepsy diagnosis is commonly starting on the age of 18 and after 50s. So there are 2 peak populations. One is children and the other is senior population. And the cost of treating epilepsy, it could be humongous. Just calculating the medical cost, direct medical cost, it costs up to $1 million. And that is not counting the social and economic costs associated with family members, taking care of the children, and the lost opportunity to contribute to productivity and so on. So it's very hard to estimate what is the real cost of really having epileptic children suffering from lifelong epilepsy. Now, I briefly touched on cause of epilepsy. The cause of epilepsy could be very variable depending on the age of onset. For example, when you see a seizure starting in infancy and childhood, it could be from birth injury, it could be a metabolic disorder, it could be congenital malformation. On the other hand, if a child was normal until certain childhood age and start having seizure at the age of 5, 6, you have to look at different causes such as genetic syndrome, CNS infection, brain tumor, and so on. Now, in adolescents and young adults, most common cause of new onset seizure or epilepsy is head trauma and drug intoxication, and certain lifestyle issue. For example, someone cramming for a final exam and getting sleep deprived, they could have seizure, but it doesn't mean necessarily they have epilepsy. I just mentioned that all the adult senior population could have new onset seizures, mainly because they have a different type of neurological disease such as stroke, brain tumor, and other metabolic disorders. Now, before we go into detail about how epilepsy affects children and how to make a diagnosis and treat, I'd like to just give you a very brief instruction how to manage acute seizure. We call it first aid for seizures. The first thing you do when you find a person seizing in front of you, the first thing you do is really turn the person aside with head towards the ground. The idea is that just to make sure that the child or the person seizing and vomit and aspirate. So that's really the ultimate cause of death when a child or epileptic person die during the seizure. So to prevent that, you really have to keep the person on the side, or at least the airway is not blocked by some vomitus or some food debris in the mouth. Then you have to consider whether the child needs to be transferred to a nearby hospital or not. And I emphasize this, most of the time, 99% of seizures will not lead to any significant medical issue, meaning that most of the time seizures could be just observed in a safe position and safe place and don't have to take them to the emergency room. Now, the conditions you have to consider emergency room visit is when a person is having multiple seizures in front of you or having prolonged seizures. So in other words, you started observing seizure a minute ago, and now it's 5 minutes later still continuing. Then you have to consider that this person is going into status epilepticus or prolonged seizure. Let's say that the person with seizure is actually pregnant, you know that, and the person is injured or the person has diabetes, then you have to consider taking them to the emergency room right away. Probably you may not know whether this is a new onset seizure, but if you know the person and this person is having the first seizure, you have to take the person to the emergency room, mainly because this could be the beginning of serious neurological or medical disorders. The final thing is, do not put anything in the mouth or do not try to restrain the patient while the patient is seizing. Number one, it's not going to help stop the seizure. Number two, it could actually harm the person by doing that. So now you have a child that had a first seizure. What do you do? So the first question you have to ask yourself and your doctor is really whether the event you observed with your child is a seizure or not. And the second question is this the first seizure? Is the first seizure really indicating beginning of a acute or chronic neurological or systemic disorder? For example, people with meningitis, encephalitis, stroke, bleeding, they all could really manifest as seizure as a first symptom. Some metabolic genetic disorder could present as a seizure as well. So if you just focus on the seizure itself, you may not really get the big picture. In other words, the big picture may be some treatable disease that you may be just ignoring. So it is very important to find out whether seizure is part of a bigger neurological or systemic disorder. Next is really to find whether there's any acute trigger. In normal people, in healthy normal children, just having low sugar or low sodium or low calcium could lead to a seizure. It doesn't mean that the child has epilepsy, but the fact that they had a low electrolyte or low blood sugar may have triggered the seizure. So it is very important to know that the condition just mentioned is ruled out, so that we don't have to put somebody on unnecessary seizure medication. The next question is, do I see a neurologist when I have a child with a new onset seizure? The answer is yes. Whenever your child has a new onset seizure, you have to see a neurologist. And I will emphasize this again and again, mainly because seizure is just a symptom. So you need to find out what is actually causing the seizure. So once you ruled out the acute neurological or significant medical disorder, then probably you don't have to see a neurologist every time. But it is very important, at least for the first seizure, you need to see a neurologist. Then final question is, do I need to start seizure medication or not? Again, this answer will be best answered by your neurologist. So we just mentioned about seizure precipitants. So what are the common cause of acute seizure without having epilepsy? So low blood glucose, this is commonly found in diabetic children. So you have a diabetic child who is on insulin or some medicine, and they're supposed to take the medicine and take food. Unfortunately, let's say child has a acute infection they cannot eat or they cannot digest, then their blood sugar drops precipitously, and that could lead to acute seizure. It doesn't mean that they have epilepsy or they need seizure medicine, all the evaluation. Just the fact that the child has diabetes and not eating properly, that could explain the whole seizure episode. Low sodium could happen with certain medical condition. Certainly you have to rule that out. Low calcium could also cause seizures. Low magnesium. Now certain antidepressant or the stimulants for ADHD treatment could cause seizures. Now this is sort of not common, but it is documented. When you're on some sleeping pills or sedative for long enough time and try to stop the medicine without tapering off, you could have a sedative withdrawal seizures. Severe sleep deprivation is known to be a cause of acute seizure, especially in young children or young adolescent who is really cramming for final exam and so on. So that should be considered. So we just mentioned the cause of different cause of acute seizure. So because we have to rule all of this out, we have to start with really detailed history and neurological exam. That's typically provided by a neurologist. And then you have to do some basic blood tests that include CBC, electrolytes, glucose, hepatic panel, and renal function. All of this testing is just try to rule out acute metabolic cause. And in some cases, neurologists may recommend a lumbar puncture to rule out CNS infections such as meningitis and spondylitis. And it is very, very important that neurologists make the decision in timely manners. So, for example, if your child started developing encephalitis and if you miss the window of diagnosis and treatment, it could lead to severe neurological outcome. Urine screen for drugs is important, especially in adolescents who may be having some drug withdrawal or acute drug intoxication. Finally, we recommend two tests. One is EEG, or we call it electroencephalogram, and the other is neuroimaging studies such as CT or MRI. So what is EEG, or electroencephalogram, and what does it mean when you have abnormal EEG? When you run EEG on epileptic patient, you will find certain findings we call spikes, sharp waves, or spike wave complexes. These are very, very characteristic findings associated with epilepsy. However, more than half of epilepsy patients show normal EEG, meaning that the first EEG at doctor's neurologist's office may turn out negative, but it doesn't mean that your child does not have epilepsy. So normal EEG or negative EEG does not rule out epilepsy completely. On the other hand, up to 4% of normal children has abnormal EEG, such as spikes and sharp waves. So actually, even though the EEG demonstrates some abnormality, it doesn't mean that you have to automatically start treatment or you have to consider your child epileptic. The next question is brain CT or MRI, and this is probably one of the common questions I am asked. CT could be done in acute setting, especially in the emergency room, to rule out gross abnormalities such as brain tumor, hemorrhage, and stroke. But most of epilepsy patients, especially I would say in children, do not have this condition. Rather, they have a very subtle abnormality or have normal MRI or normal brain. So CT is seldom helpful as a elective diagnostic tool. It could be a good screening tool at the acute emergency room visit setting, but never should be done in outpatient setting or neurologist's office. When I see children with chronic epilepsy, they have done several MRIs, really without any specific goals in mind. So in other words, you repeat MRI, even though the first MRI is negative, really doesn't give you any additional information unless the seizures are poorly controlled and surgery is considered. So my advice is, if you haven't done any MRI and your child has epilepsy, get an MRI. If the first MRI was negative, you don't have to repeat unless you consider a surgical option. Now, choosing anti-epileptic drug or anti-seizure drugs could be usually determined by a neurologist. And as a neurologist, I consider multiple factors such as seizure type, epilepsy syndrome, pharmacokinetic profile, drug interaction with other medication the child is taking and other medical conditions. And you also have to think about cost, because not all the parents or not all the families can afford to have a very expensive medication prescribed and refilled. So we have more than 12 different medications for different types of seizures, and this should be left to the neurologist seeing your child. But I want to emphasize that the certain drugs work only for certain seizure type. So, for example, carbamazepine is a really very effective drug for partial epilepsy, but not necessarily for the generalized epilepsy. So how do we know what type of epilepsy your child has? That also should be really left to the neurologist. And typically, after the EEG, after the MRI, your neurologist will be able to determine what type of seizure or what type of epilepsy your child has. I emphasize monotherapy because when you're on multiple drugs, it's very difficult to know which drug is causing side effect or which drug is working or not. So again, it's very important to consult with your neurologist, but never consider adding more medicine, meaning better control. If you fail more than 2 drugs, you definitely have to consider seeing a specialist, because there is well-established data when you fail 2 anti-seizure medication and your child is seizing continuously. Actually, they need to have a very detailed evaluation, and you may have to consider non-medical or other alternative options, including brain surgery. I just mentioned drug interaction briefly. Some seizure drugs could inhibit the effectiveness of other drugs in various different ways. And that's one of the most important reasons why you should not keep adding more drugs to whatever the child was taking. Another question I hear often from parents is, why do we check the blood level of medicine? Well, probably the most important reason we check blood level of medicine is that when a child is not doing well. In other words, we prescribe medicine, a child is taking the medicine, and still the child is seizing. So we want to know why, and number one reason could be that child is taking medicine, but it is not enough. So in other words, it's not really hitting the therapeutic target. So by looking at the blood concentration, we could actually adjust the dosage of the medicine, and we can look at the drug interaction and so on, and that could be probably number one reason. Now, having said that, I do not recommend checking drug level in every single child, mainly because a drug level may not mean really much, especially when a child is doing well, has no side effect. So I recommend going by clinical observation rather than the number of the drug level. So you study medicine because your child has nuanced seizures. So what do you expect? Now, 70% of children, when you start seizure medication, they respond, meaning that they stop seizing and they continue to develop well. On the other hand, 30% of children continue to seize. So what do you do when your child is on medicine or two and still seizing? So these are the considerations you have to give. Number one, is my child having some sort of progressive neurological disorder? There are many conditions that could be belonging to this category, and probably the most prominent one is brain tumor, or we have some certain conditions such as Rasmussen encephalitis, focal cortical dysplasia, and so on. So when you have the certain pathology, no matter what you do, the child is going to continue to seize. Then the second question is avoidable precipitant. Let's say the child has a very bad lifestyle. So in other words, like, child is, let's say, 13-year-old and has a very bad sleep hygiene. They don't go to sleep until 2 or 3 a.m. and they don't take medicine as well as they're supposed to, and so on. They need to really fix the lifestyle first. The third one is it's a real issue. So you're on this first drug and you failed, meaning that your child continue to seize, and then you replace the first drug with second drug and your child is still seizing. Then you have serious problem. So the real question here now is, well, is there any problem with drug absorption? So my child is taking medicine. Is the drug going into the system? Then the question is the dose enough? So then you have to really check the drug concentration and increase the dose. How about medicine? Maybe the medicine is not the right medicine for the specific seizure type my child is having. So maybe you should consider changing medication. Then finally, before you go into the next step, you really have to consider doing video EEG. The reason for that is, again, certain drugs work for certain seizure types. Now, a lot of times, if your child has one seizure every week or every other week, it's very difficult to capture or document seizure in the hospital. So in the typical setting, your neurologist will go by what you describe for your child's seizure. Unfortunately, just depending on the description of seizure, you may not get necessarily very accurate seizure characterization. So the medicine your neurologist is prescribing may not be the best medicine. So in that case, what you have to do is really put the child in inpatient setting, off the medicine, and document the seizure so that you can characterize the seizure better. So you have done all of these steps and still you're seizing, meaning that you have tried first drug, second drug, and your child on third drug and still seizing. And that means really the child is having something called intractable or drug-resistant epilepsy. The next step should be really going to the comprehensive epilepsy center near your home. So what are the red flags? I just mentioned, continuous seizures despite medication. In addition to that, there are certain factors you need to consider so that you could actually have early referral to a specialist or to a comprehensive epilepsy center. So number one is you're failing 2 or 3 drugs, and second is you have a sudden increase of seizure frequency and appearance of new types of seizure. We call it kind of explosive conversion. So your child was having maybe 1 seizure every 6 months and doing well developmentally, and suddenly your child is having like daily seizures and losing skills, and that's a red flag. Something really is not going well. As I said, the child has developed cognitive or neurological deficit. That's a red flag. And your child has experienced very prolonged seizure lasting longer than 20 minutes, 30 minutes. We call it status epilepticus, without a specific trigger, such as drug withdrawal or head trauma and so on. And really, when you have a seizure like that, very prolonged seizure, the chance that you will have another prolonged seizure is very, very high, and the mortality or morbidity from that prolonged episode is very, very high. Finally, the first MRI showed a lesion, and your child is not responding to medication. It is very likely that the lesion is the reason why the child is seizing, and unless we take care of the lesion in the brain, you may not really have a good response from medicine. So those are the reasons why you should consider referring your child to, or taking your child to a place where very comprehensive and detailed evaluation can happen. So to summarize what I said, when I see a child in clinic, after the physical and neurological evaluation, and after getting very detailed history, after I get EEG and MRI, I kind of sit down myself and try to really categorize into a certain diagnostic scheme. And my scheme is actually 4 different categories. Number 1 is epilepsy diagnosis made wrong. In other words, somebody made a diagnosis of epilepsy, but the child does not have epilepsy. In this case, the child will not really respond to medication very well, obviously, because they don't have epilepsy. The second category is the epilepsy that will respond to medication and will go into remission no matter what I do. So these are, we call it benign childhood epilepsy, or sort of self-limited epilepsy. They have epilepsy now, but I know, I'm almost certain that the child will go into remission in time, regardless of medication. The third category is, we call it drug-resistant or intractable epilepsy, but may respond to alternative treatment such as surgery or ketogenic diet. The fourth category is epilepsy that we know for sure will not respond to medication, in other words, intractable, but the accurate diagnosis may only provide closure to the situation. In other words, surgery or diet may not really be the answer to the epilepsy. And typically this condition is either genetic or metabolic disorder, and there's no known treatment. So I'm going to actually show a few cases that I treated in the past. So let me start with Josh, who was 80-year-old. He was right-handed. His seizure started at the age of 5, and he was having mostly nocturnal episodes. The description I got from family was that he will wake up in his bedroom and come to the parents' room crying inconsolably. He went to the neurologist's office, had an EEG that showed a few left central temporal spikes. Again, it's basically, this is sort of characteristic finding associated with certain epileptic condition. Because of this finding, the neurologist started medication, but he continued to have 1 to 2 episodes every week. So now he's 80-year-old. He's been on different medication for almost 3 years, and he's still having these episodes. And he had 3 MRIs for the past 3 years, so 1 every year, and all of the MRIs were normal. We did video EEG. Remember, I told you that when a child continues to seize with proper dose and proper duration of treatment, the first thing you have to do is really try to characterize seizure type first. Actually, not only characterizing seizure, but also confirming whether the child has epilepsy or not. So we did that. We brought the child into the video EEG monitoring unit. We stopped the seizure medicine so that the child could have seizures. And when we did that, actually he did not have any episode of seizure. We did not see any clinical seizures. However, we saw some events. He will wake up in the middle of the night and very, very irritable and go back to sleep. And when you looked at the EEG, in the middle of the episode, we found absolutely normal EEG. What it means is that the child's episode was some sort of sleep disorder we call sleep terror or sleepwalking. And apparently this EEG was overread. So there were certain findings, certain features that neurologists may think abnormal, but it was essentially just the normal variation, not the truly abnormal EEG. So we referred this child to a sleep medicine specialist, and obviously we stopped seizure medicine, and he's been doing very well without any episode, with just a small amount of sleep medication. So the point I'm trying to make here is that parents' history is very important, but could be misleading. And we could have multiple seizure-looking events, we call it non-epileptic events, commonly misdiagnosed as epilepsy. To make the matters more complicated, EEG can provide some information but does not necessarily make the diagnosis. This is a very, very important point. Normal variants are very, very common in pediatric EEG. Also, you have to remember that 3 to 4% of normal children could have abnormal EEG. So because your child had some unexplainable events, and because your child had abnormal EEG, you should not really jump on the diagnosis of epilepsy and start medication. Now, for some reason, your child has been diagnosed epilepsy and again, not doing very well on medicine, then you have to go back to the really basic question whether your child has truly epilepsy or not. And in that situation, video EEG for prolonged time, maybe up to 5 days, could be the only way to prove or disprove that your child has epilepsy. Second case was a 12-year-old girl who had epilepsy, and the diagnosis is based on clinical history. Mom reported her seizure study at the age of 8. She continued to have daily seizures despite trial of 8 different seizure medication. She had multiple MRIs, routine and video EEGs, and many, many emergency room visits in the past 5 years. She was referred to us. We did very comprehensive epilepsy evaluation, and our conclusion was that the child did not have seizures. She was having a diagnosis called psychogenic or non-epileptic seizures. And this condition is commonly associated with depression, anxiety. In some children, you can actually find some child abuse, physical or sexual abuse history. So this is a really hardcore psychiatric diagnosis. Obviously, seizure medication will not help the child. So after the correct diagnosis, the child was sent to the psychiatrist, and she stopped having seizures. So again, misdiagnosis is very common in pediatric epilepsy. I can cite a few papers. For example, British Medical Journal 2002 had a report saying that 1/3 of children treated for epilepsy turned out to have non-epileptic diagnoses, such as syncope, such as non-epileptic seizures, and so on. And another paper published by Dr. Hamika in Nationwide Children's Hospital, new onset seizure clinic, 24 to 35% of referral had no epilepsy or just non-epileptic seizures. So these are actually children who had garden variety of epilepsy. Most importantly, very, very interesting paper published in 2006 says that about 39% of children referred to comprehensive epilepsy center because of refractory seizure turned out that they had no real epilepsy. They had non-epileptic seizures. So again, misdiagnosis is very common. When your child is not doing well, the first thing you have to consider is whether the diagnosis is correct or not. So what are the consequences of misdiagnosis? Well, you can actually miss treating the real diagnosis. For example, your child may be having cardiac problem like arrhythmia. Your child may be having GI reflux, acid reflux. Your child may be having psychiatric issues. And these could be completely ignored while you are focusing on epileptic diagnosis made wrong. You cannot ignore the side effects of multiple anti-epileptic drugs. And when you have a diagnosis of epilepsy, you have certain limitation with your lifestyle. You cannot go to certain trips. You can go to sleepover. So there's huge limitation or restriction with a normal childhood life. Quote-unquote stigma of having epilepsy is still a significant issue, especially if you're a school child. And the other thing is child abuse concerned. Some parents may report seizures for certain financial or social or psychological gains. And if you miss the diagnosis, actually the child suffers greatly. So these are the list of non-epileptic seizure or non-epileptic condition that can look like or that can mimic seizures. I mentioned some of them: panic disorder, movement disorder, sleep disorders, and breath holding spells. The third case illustrates why you should see a specialist when your child starts seizing as a new onset or new seizures. So this was a 2-year-old right-handed female who had first seizure at just months before admission to the hospital. The seizure involved the right face, arm, leg, and lasted about a minute. So it could be just any other common seizure type. I mean, it wasn't really anything specific. However, when child had this first seizure, it did not stop there. She continued to have seizures. So she had 3 seizures the first day, second day 5 seizures. The third day she had almost non-stop seizures. So this is one of the red flags. When your child starts seizing and seizing really explosively, then you need to be concerned about something else going on. So in other words, this is a beginning of some dangerous medical or neurological condition. So make a long story short, she was sent to the emergency room where they did spinal tapping and found out her spinal fluid had inflammatory cells. Because of the abnormal CSF exam, she was treated as an inpatient with antiviral or antibiotic medication. Now, after that, we kind of expected she's going to improve, but after a week of a little bit of improvement, she came back with the same amount of seizures. So we started doing a little more detailed evaluation. Around the same time, also mom reported that she started having slurred speech. This is another red flag. Remember, I told you that explosive seizure, and the second was an additional or new neurological deficit. So she started having some slurred speech, which is a neurological deficit. And we did video EEG monitoring, and we looked at different causes of epilepsy. And what we found was that her brain MRI was abnormal, showing a multiple lesion in the left side. And PET scan was also very, very abnormal. This scan shows a huge increased metabolism involving the left hemisphere, which was abnormal also on MRI. So when you had this testing, we had to rule out 2 different conditions. One was Rasmussen encephalitis, and the other one was NMDA receptor antibody encephalitis. Now, I do not have really time to explain what are the differential diagnostic point, but the point I'm trying to make is because she was referred to us, we were able to make a very accurate diagnosis in very short amount of time, and she ended up having a positive antibody against NMDA receptor, which is suggesting that she has an autoimmune encephalitis, and she needed specific treatment with immune suppression. So she ended up getting immunoglobulin and IV Solumedrol, and her seizure completely stopped, and she is developing as a normal child. The point I'm trying to make here in this case is that if this child was not referred to us in time and did not get accurate diagnosis in time, she could have been really, she could have gone into really bad situation. She could have lost her life, literally. So again, seizure is a part of the symptom, part of the disease manifestation. There may be some treatable or some condition you need to treat acutely with accurate diagnosis. So instead of just looking at the seizure, we need to really look for specific reason why the child is having the seizures. And this is clearly the case when your child has start with very explosive seizures and have some neurological deficit with seizures. So this is a final case, and this was 10-year-old who started seizure at the age of 10 weeks. So she suffered for seizures almost 9 years. And from the get-go, she started daily seizures, 2 to 3 times per day. Every time her seizure was about 3 to 4 minutes. She failed 12 anti-seizure medication for the past 9 years. She did not develop well. She's 10-year-old now. Her functional level is about 3-year level, and she could not talk. So we looked at her MRI, and her left side MRI, her left side of brain is completely abnormal. And this is a example of focal cortical dysplasia involving whole left hemisphere. And when you look at the PET scan, whole left hemisphere, especially the posterior, the back part of her brain has no metabolism. So it is structurally there, but it's not functioning. And we have done some other testing, we call it SPM PET, shows the same area, left temporal lobe and frontal lobe abnormality. We did another test called SISCOM, SISCOM, which is showing the blood flow change at the time of seizure, which indicates her seizures coming from the left hemisphere as well. So with all of this testing, we are convinced that her seizure was coming from the left side. The question was, how do we make a seizure free? So the next step was actually placing the electrodes inside the brain to narrow down the seizure focus and to map the important functions so that we could spare important functional areas and have the best possible outcome. So we have, this is a picture that was taken in the OR that shows real brain with the intracranial electrodes on. And this is 3D reconstruction of the brain that shows the location of individual electrodes. And this is an EEG that we get from intracranial EEG. And when she was seizing, I was able to see that her seizure activity is coming from all over her brain. So we tried to spare her important function, but our conclusion was that her whole hemisphere was involved in seizure activity, and we could not spare any function if we were to stop her seizure completely. So as a result, we performed functional hemispherectomy, which is basically disconnecting left hemisphere from all other nervous system. And we found that her brain has a very abnormal structure. We call it focal cortical dysplasia, which is shown in this slide. So what is the outcome? We followed for now almost 3 years. She had no seizures since the surgery. She can walk and run without assistance. Now, prior to surgery, she was able to walk and run. However, she wasn't really ambulatory. She had to be wheelchair bound because she was having so many seizures. It was almost impossible for her to walk without getting injured because of seizures. Now that she's actually seizure-free, she can walk, even though she's having some hemiparesis. Her speech is improved, her cognitive function is improved, and most importantly, her quality of life is dramatically improved. Her family can make a planning for vacation. She can attend regular school, and she can go to any place if she wants to, with or without assistance. So this made a huge improvement in the whole family and patient's quality of life. So what are the options? We just mentioned some cases that actually we were able to treat bad refractory epilepsy with surgery. Is the surgery only option? Well, so when your child has refractory or drug-resistant epilepsy, these are the things you have to consider. Number one is surgical evaluation. The surgery, brain surgery, is not the last option. Brain surgery is actually the best option if your child is eligible. I'm saying it again, the brain surgery leads to the best outcome, best possible outcome if your child is eligible. If your child had surgical evaluation and not eligible for surgery, then you should consider ketogenic diet. You should consider vagus nerve stimulator. So what is ketogenic diet? It's basically you're taking a certain diet composed of mainly a fatty acid that will induce ketosis and acidosis in systemic blood and possibly in the brain, and that could lead to improved seizure control. This diet has been very effective in certain population, especially when a child is getting diet through G-tube and child does not know the taste and so on. And when child has no other option, for example, surgery is not an option. And I think the ketogenic diet should be considered as a next step. However, we do not know the long-term effects of this very unbalanced diet. The problem is that we have probably done this treatment for last 10, 15 years, but we don't know whether this is going to have long-term metabolic effects 20 years or 30 years later. That needs to be established. Vagus nerve stimulator is an electrical device we implant in the subcutaneous tissue that stimulates the vagus nerve, and we don't know exact mechanism, but it seems to decrease the seizure frequency and severity in about half of the children or adults getting this device. So I consider this as another drug without drug-related side effects. But it involves some minor surgery, certainly without risk, and it has some side effect as a result of continuous stimulation of vagus nerve, such as hoarseness and throat discomfort and dyspnea. If your child has a certain sleep apnea or obstructive sleep apnea condition, vagus nerve stimulator may not be an indication. I kind of showed the example of how we approach the intractable epilepsy patient with surgical evaluation and so on. The criteria for surgical treatment is that the child has failed at least 2 or 3 primary anti-seizure medication and still seizing. The second criteria is that we have some evidence, we have some data that we can find the location of seizure focus, and we can find the extent of seizure focus, and we can confirm that number of seizure focus is not more than 2. Now, when you have multiple seizure focus, we could still consider surgery, but it's going to be more difficult and more challenging and may not be as successful as someone who has only 1 seizure focus and 1 seizure type. Now, surgical treatment option, definitely curative if you know the seizure focus and you could go after the specific location. However, even in the case where we cannot find a one seizure focus, we could provide surgical options such as colostomy or other palliative treatments such as multiple subpiral transection. So this table actually illustrates the overall outcome when you talk about resective surgery, depending on the location of seizure focus. For example, temporal lobe seizure focus has about 70% seizure freedom rate. If you go outside of temporal lobe, it drops down to about 50%. When you do colostomy or hemispherectomy, the seizure freedom rate is about somewhere between 10 to 50%. Definitely you have to consider colostomy if your child has multiple seizure focus, and resective surgery is not an option, but your child has a very severe grand mal seizures or drop seizures. Colostomy should be strongly considered. So I spent about an hour to go over important points that you should be aware as a parent who have a child with epilepsy, whether your child has a very benign epilepsy or very refractory or drug-resistant epilepsy. Now, I want to sort of summarize what I said, just kind of itemize from the beginning of seizures until your child goes into remission or your child goes to see a specialist. So number one is that nobody can be advocate for your child when your child has a seizure. So parents should be an advocate. And you should be really asking specific questions to your doctors. Number one, what is the seizure classification? What is epilepsy classification in my child? Number two, is there any specific etiology? Is there certain etiology you should you can treat, or you should consider that as soon as you know there is a certain etiology, you may have to consider surgery. So finding etiology is very important. You got to ask your neurologist what's going on, what is causing my child's seizures. And another important question is, what is the long-term plan? What is plan ABC? So my child is doing well, so how long do you want to continue medication? My child is not doing well, what is the next plan? What is the plan B? Second, the abnormal EEG. When you hear from your neurologist that your child has abnormal EEG, it doesn't mean that your child has automatically epilepsy. You have to discuss the implication of that with your neurologist and make the decision mutually, not just one-sided. You need to consider your child's lifestyle, the other medical condition, and decide together with your neurologist. When you have a child and have a sort of established epilepsy and experiencing seizures despite medication, you should not be taking your child to the emergency room every time your child sees. Unfortunately, when your child sees in front of you, this is a medical emergency. However, when you take your child with a known epilepsy diagnosis to the emergency room, there's really not much the emergency room physician can do. So it is really just wasting your time and resources. And sometimes it's harmful to your child. So the condition you should consider taking your child to the emergency room is that if this was the first seizure for your child, and you suspect that the child is having underlying neurological disorders such as meningitis and spondylitis, and the child's seizure was prolonged more than 5 minutes, and child doesn't wake up from seizures after 30 minutes or so, and this is very important. If your child had an established diagnosis of epilepsy, do not repeat CT every time when you go to emergency room, because it's not going to help you. Number 4, anti-epileptic drug is a misnomer. Anti-seizure medication is probably the right name, and most of epilepsy, I would say up to 70% of childhood epilepsy is self-limited. Whether you treat or not, or whether you treat with certain medication or not, more likely than not, your child epilepsy will go into remission. However, about 30% of epilepsy in children do not respond no matter what you do. And that's when you need to see a specialist to find out what's going on and to find alternative treatment. Another thing is that, as I said, if your child has a new onset seizure, the likelihood that your child will go into remission is about 70%. So the next question is, how long do you continue the medicine? So your child has no seizure for a year, you should really consider tapering off medication. Obviously, you need to do this with your neurologist. Number 5, multiple medication is not proven to be more effective than single medication. Multiple medication is not as effective as monotherapy or single drugs. When you're on multiple medication, you don't know which one is causing benefit or which one is causing side effect. So make sure that you talk to your neurologist, try to simplify medication as much as possible. Another consideration is the child with refractory epilepsy could die suddenly, either during seizure or during sleep. We call it a sudden unexpected death in epilepsy. And one of the significant factors is polytherapy. So when a child is on multiple medication, we don't know how it happened, but certainly increase the risk of sudden death in epileptic children. So again, polytherapy is not better than monotherapy, in my view. The majority of pediatric epilepsy is self-limited, but as I said, 1/3 is refractory, and they should be referred to a specialist. When I say specialist, I'm talking about comprehensive epilepsy center where you can meet neurologist, neurosurgeon, radiologist specializing in neuroradiology, neuropsychologist. Just try to look at the whole aspects of epilepsy in your child. That's the best way to find the alternative or ultimate treatment for your child. Number 7, the epilepsy can affect cognitive development. When you have enough number of seizures, you will actually see that your child experiences some decline in cognitive function. It may not be necessarily due to the seizure medication. It could be both, but we know that it is well established that when you have very bad epilepsy, very frequent seizures, the cognitive development in children could be impaired, and it could be progressively declining. And the only way to stop the progression of cognitive decline is stopping seizures completely. When I see the children with epilepsy, again, my first goal is to stop the seizure, but the child has multiple different issues. When you have long-standing or chronic epilepsy, the child develops other comorbidities such as depression. There is increased risk of suicidal attempts and success. And there are a lot of psychosocial issues, driving, education, employment issues, family dynamics, and I mentioned a little bit earlier, SUDEP, or sudden and unexpected death in epilepsy, is not something that we commonly discuss, but it is real. There is about 6.5 children dying every year out of 500 chronic epilepsy patients. So it is real, and unfortunately, unless you discuss the possibility of all of this comorbidity and other issue, you can actually miss the timing of proper treatment, proper referral to a specialist. My final point is, when you consider your child has intractable epilepsy and consider surgery, the best time is yesterday. It's not tomorrow or next year. So as soon as you realize your child is not responding to medication or combination of medication, you should consider whether your child could be referred to a specialist and consider for alternative treatment, including surgery. And the success rate from surgery without neurological deficits is becoming higher and higher every year, especially with advanced technology and especially with a multidisciplinary approach and multimodality imaging approach. And even in the same child, when the surgery is done earlier, the recovery, it could be much better, much sooner. So I have tried to cover major points that I think important to manage children with epilepsy. And certainly there are many things that I haven't covered. In my view, the epilepsy is not a single medical problem. It affects the whole aspect of a child's life and development. And not only that, actually, it could affect whole family and community. Most of children will be responding to medication without significant side effect and going to clinical remission. And those children are very well managed by most of neurologists in your hometown. Now, when your child is not doing well, when your child is still seizing despite medication, and your child is experiencing some neurological decline, cognitive decline, those are the red flags. Unfortunately, timing is not in favor of your child and you should be the advocate to find better solution, find an alternative treatment for your child. And the earlier the better. So if you have any questions regarding my talk today, please submit a question online, and I'll be glad to get back to you within a few days. Also, if your child seems to have intractable or drug-resistant epilepsy and you want to find out more about alternative treatment options or specific diagnosis, I'll be very happy to see your child. Please press the button on your website and we will set up an appointment with you. Thank you.